Well, I was planning to come anyway. That is a really pretty dress. That is actually spectacular. And the little rabbit. Yeah, no, very pretty. Have a seat. Oh, you get to sit with the cool kids too. I tried to buy, oh no, the spring is he just got back from eternity. They did. There's something it doesn't smell. It doesn't smell. Right. You know what
Hi there, how are you? All right.
As a boy,
All right. All right, good afternoon. Let me get started. So welcome everyone to the HPC's Advisory Council meeting, our summer edition of the HPC Advisory Council meeting. I hope everyone is having a great summer. We are certainly having a great summer here at the HPC. Busy as always, but summer is a particularly exciting time for us at the HPC because we have an amazing program that we've run for the last couple of years where we have a fellowship program and have summer fellows who work full-time at the HPC for a number of different undergraduate and graduate programs and contribute to different projects at the HPC. So I'm going to just ask them to quickly stand. They're all behind me. Come on. So just an amazing group of young people and young professionals who are contributing to healthcare policy. So thank you so much for the work you're doing. It's our largest fellowship class ever, and I think they account for almost 15% of the bodies that come into this office every day. So it's a huge influx of talent and excitement to our work. So for today, we are grateful to have with us a number of our commissioners, Chair Stuart Altman and Commissioner Don Berwick. Thank you both for being here today. And we are expecting Undersecretary Allison Moore to hopefully be joining us today as well. So thank you for being here. For today's meeting, we have a few agenda items to walk through. I think we have scheduled us only for an hour and a half today, so a little bit less than our usual 2 hours, get you out of here and enjoying summer. So Really, our main focus today is to, yes, it's that time of year again, to start talking about the cost trends hearings, and to get your input and feedback on what are those priority areas that we should really be focused on this year for our cost trends hearings. I've always greatly appreciated the input and feedback from this group in terms of designing and every year improving the cost trends hearings. And so we are proposing or considering a couple of structural changes this year, which we'll walk through, but really both want to hear your thoughts in terms of content, but also the format with which we conduct these hearings to have them be as impactful as possible. We're also going to start off, though, with a little bit of a data presentation, which I'll tee up a little bit later, but very excited to present some new CMS data that compares the United States to Massachusetts to the United States and to many other states. This is an update of some validated information, and I think provides a really interesting lens into areas where we have made some progress in Massachusetts and some continued areas of challenge. And I think the data is one in which I'm really hoping to get some of your insights into whether this is consistent with your own perspectives on what you think has happened over the last few years, whether you have some areas of surprise in terms of the numbers, and I think specifically where we can take this data analysis next in order to fully provide further insights into healthcare spending in Massachusetts. So with that as just a quick tee up, we do have a number of kind of designees here among our normal advisory council members, so I do think worth going around the room and just introducing yourself and your organization. And we are webcasting this meeting as well, so please try to use the microphones. A key strategy with the microphones is when you press the button, there's like a 1/2 second lag between when it turns from red to green. So don't just keep jabbing at it. Just give it a 1/2 second and it should turn green. So I'll start going on this way with the HBC staff.
Great. I'm David Auerbach. I'm the Director of Research.
Hi, Colleen Elstermeyer, Deputy Executive Director.
Steve Walsh, Mass Council of Community Hospitals.
Rabio Association of Behavioral Healthcare.
J.D. Cheslaw from Massachusetts Business Roundtable.
Hi, Laurel Sweeney with Willis.
John Irwin with the Conference of Western Teaching Hospitals, and my apologies, I had to leave early.
Cheryl Piscacci, I'm the nurse practitioner on the chart team at Bay State Franklin.
Dave Spackman, Lady Health.
Karen Granoff, National Hospital Association, City of Midland. Nick Logan, I'm representing Mass Home Care.
I am Monica Sun from SL2 for Dead Center.
Marcy Sindel, Adrian Health.
Ron Nowak, Massachusetts Medical Society.
Megan Collins, Mass Nurses Association, City of Midland.
Ben Agatston, representing Healthcare for All.
Kim Haddad from Commonwealth Medicine UMass Medical School, here for Joyce Murphy. Laura Pellegrini, Mass Association of Health Plans.
Although my preference is differently, but Polyatlas Greater Boston Organization.
I'm Paula Sue, Cheryl Bartlett, although my practice as Laversa Health, I started Monday as the new CEO of Greater Bedford Community Health Center.
I'm Don Burwood, Commissioner.
I'm Stuart Altman, Chair of Health Policy.
Great. Thank you all for being here again, and congratulations, Cheryl, on your new position. I'm sure you'll be a success. So to just dive right into our data presentation today, as I teed up, this is CMS data that is revised and updated on an infrequent basis, not as often as we like. I have been using some of this data dating back to 2009 in my public presentations for really about the last 4 years of working at the HBC. And every time I presented this data, I kind of had to caveat it by saying, this is really old, it only goes through 2009, I'm sure these numbers have changed. And so I will share with you that we did a little bit of a happy dance at the HBC about 2 weeks ago when we saw that new updated information had been distributed and issued publicly that updates this information through 2014. Still, obviously, a couple years of lag, but definitely provides some new insights into our healthcare spending trends. And so to move straight to that data presentation, I'm going to turn it over to David Auerbach, our Director of Research.
Thanks, Nick. Okay, so I don't need to give too much more background. David did a good job teeing this up, but just to reinforce, this data is released in 5-year chunks, and we now have data through 2014, so I'm going to be showing you trends going all the way back, in some cases, to 1991, and highlighting some of the interesting findings that we have here. These data are, the great thing about it is they're based on the same sources for all states in the country. It's apples to apples. We've been doing our best with CHIA data, which is close, but this is sort of the gold standard of comparison that we have. These are based on provider and payer surveys and administrative sources. And CMS produces data based on the residence of the individuals in the state, also residence of the providers. This is based on the residence of individuals. So this is where people live, how much are they spending in different categories of care. It's the same as the National Health Expenditures data, basically the same data, but at the same time. Okay, so to start off, I'm showing where we were in 2009 and where we are in 2014. The top half is the 2009 total spending per capita, state by state. So last we knew, we were the highest spending state in the country, quite a bit above the second highest state. And we, as David saw the show, we've often used this data. Our cost trends report often started with that, and we've been very curious to see where we would turn out once the new 5-year set came in. And as you can see on the bottom, by 2014, we are no longer the highest spending state in the country. It's very exciting. We're still number 2, but there's some distance now between Alaska and Massachusetts. Alaska is number 1. And that actually is a significant deceleration in our cost growth, as I will show on the next slide.
Just quickly on this particular one, the difference between Massachusetts and the United States in 2009 was a 37% difference, and by 2014 that was a 31% difference in the per capita spending.
Exactly. So to get from 37% above to 31% above, we must have grown slower than everybody else. And the next slide is showing that.
There's a quick question. Is this per capita including research, NIH budget, or is that excluding? It does say personal healthcare spending. When I go on KFF's Kaiser Foundation site, they use the same numbers, but use the term, well, healthcare expenditures per capita, so it's not clear if we're using the NIH or research.
This is per capita, but you're right, personal healthcare spending omits public health research infrastructure from total NHE, so that shouldn't be in these numbers. It should not be. It's hard to divvy those up in this thing. Okay. So this one is showing your rates of growth between 9 and 14, so the average annual growth rate at which each of these states grew in their state. And here you can see we are on the far left, growing at a rate of 2.3%. Yes, please.
To what extent is that because of the increased coverage in a lot of the other states that would take spending from almost zero on some people to actually written insurance premium?
That's a good question. You'll see that more clearly on the next one where we go year by year. So a little bit of it, but not too much. Okay, so our growth was 2.3% on average per year from 09 to 14. Slowest in the country other than Arizona and North Carolina. So that is what led us to now being 31% more expensive than the national average. This one shows, like I was saying, the year-by-year growth. Massachusetts compared to the rest of the US from 1992 all the way to 2014. So here you can see the patterns and how we have grown more slowly in recent years. You can see from 2010 to 14, we were below that national average. And in the very last year, 2014, we're right. The US had a spike up. We didn't have that spike up. So that's probably, the healthcare coverage expansions in the ACA probably add about 1 to 2% to that growth trend. That's about where CMS has come down on analyzing that.
I think that as we look at this long historical chart, Definitely some different trends based on the decades. You see during the 1990s, definitely some years above consistent, some years significantly below the US, as you can see in kind of that 1999 to 2000. But pretty much throughout the 2000s, the blue line is above the orange line. And so Massachusetts was growing faster than the US throughout the 2000s. And really in about 2009, you see that trend completely shift the opposite direction. And that for every year since 2009, 2010, we've been below. Certainly, one of the things, we presented this data actually to some of our committees and commissioners a week ago, and they had a similar question around how much of this is kind of the coverage issues and the timing of the coverage issues where we expanded coverage in 2006, and the country obviously later. You know, hard to kind of parse out all of the causalities. I would also note just from kind of the state perspective, you know, we had an increasing focus on healthcare cost containment really in 2008, 2010, and 2012. So I think we always talk about 2012 as being, you know, the culmination of some of that legislative activity, but certainly in 2010 we had a major piece of legislation around small business reform. At that time, the administration, there were premium denials through the Division of Insurance. So as we think about the state's focus on healthcare cost containment, it actually does align quite well with where we see the change in that trend.
Okay. So let's move on. We're going to drill down a little farther into this data, and skipping the next slide, which is just the same thing but smaller set of figures. We're able to look at spending by category. So here we're focusing in on hospital and physician spending. The top graph is in the hospital. Again, where we last knew in 2009, our hospital spending was much higher than the US average, at $3,600 compared to $2,500 per person hospital spending. And those orange lines, the orange notes and the dotted lines are the annual growth rate between the intervening years. So you can see from 2009 to 2014, hospital spending per person in Massachusetts grew 1.8% per year, compared to a national average of 3.9, so half the national rate. And that has closed the gap, not only percentage-wise, but even in dollars in hospital spending for Massachusetts compared to the rest of the country. You can also see that we were growing at a higher rate from 2000 to 2009, part of what led to that growing gap. And the story is fairly similar, just a little more compressed on the bottom, where we've been growing in physician spending 2.3% per year, same as our total growth rate, compared to 2.9% for the US average since 2009. Okay. Now a slightly different look. We can drill down even farther into all the categories reported by CMS and ask how much more is our spending than the US average in each individual category. So this graph shows that both in 2009 and in 2014. So again, on the hospital side, in 2009 we were 42% above the US average, and that has shrunk to 28% above.
Can I make a comment about this for our web viewing audience? Bob Crawford yesterday was asked a question by one of the representatives at the hearing about how did Massachusetts pharmaceutical spending compare to other states. We didn't have an answer. This helps me as part of the answer you're looking here. They were at least 12% above the average, and we were only 7%, so it seems to be growing.
Yeah, and the next slide will also show a window into that. That's true. It's also hard to miss that our home health spending is much higher than the US average. That's 2.5 times higher. We were high before, we're even more so now. And I'll show another detail on that in a couple of slides. Smaller differences in the other categories, so the drugs is significant. And the last two bars shows again, as David said earlier, we used overall all in, we were 37% higher, and that's dropped to 31%. And we can also compare ourselves to the other states of New England, for example. We were 6% above them, and that was 4%. As in 2014. Okay. Marcy?
The home health and nursing care facilities for us, this would be very indicative, like we've greatly increased the amount of spending on home care specifically to reduce the amount of spending in nursing facilities. So
Yeah.
it'd be interesting to see the dollars here. Hopefully the spending in home health, the dollars is less than, is less than what we took out of the home care spending.
Yes, dollar slide. I'm sure that there's a lot of substitution going on there compared to the US. It's hard to be super exact about it because there's other things going on both ways, but we'll have a little more on that coming up. Yes.
I just have a question, looking at these dollars, is there,
Yeah.
behind the dollars, is there a comparison of the services that you're getting in this state versus another state? Because I'm doing some work in Georgia right now, and I see that we're too far to the left, but I think if you compare what we do in Massachusetts versus some of these other states, you're gonna see a difference in what we're offering here too. And also, if you look at the surrounding New states, how many people from Massachusetts, Vermont, Connecticut, Rhode Island are coming into Boston for medical care? And is that reflected in the overall state spend? Because I think there's a lot of that happening as well, so.
This data tries to pull out border crossing. It's not perfect, but they do the best. So I wouldn't say that's probably not a very big thing going on here, but it's a good, but it is not perfect and it happens. Yeah, the first point.
Trying to get to the left, or maybe not to the left.
Sure. I mean, this data unfortunately does not report utilization and spending, just spending. But we use other sources the best we can to get at the utilization behind it.
I think it's worth just spending, we can pause on this slide for a moment, and I do want to put the disclaimer out there that, that we're not making a value judgment necessarily about just because it's in excess of the US, that means it's bad spending or wasteful spending. Much of the spending could be providing great value to our healthcare system, to the patients and residents of the Commonwealth. So I think it's important that we not immediately assign kind of a negative reaction to some areas where we're obviously in excess of the US averages. Nonetheless, I think it still provides an insight that we need to look into and examine more closely to say, if we are spending 2.5 times more, are we getting the value that we want out of that? And that's where I think we want to continue to dive into some of these things. But this is one of those slides where I'm interested in getting some different perspectives around the table. Marcy, thank you. It seems like you're validating one of our hypotheses that the investments in home health may be related to a reduction in the nursing care facilities spending, but interested in other people's perspectives on anything on this side. Laura?
I was wondering what's in the category of other health support?
That's a good question. I don't have that on top of my head, so I'll have to get back to you. I think it's a list of things that they do say, but it's not broken up more finely, but we could get you that list. Okay. We'll get back to you.
I wonder what we know about the oral health spending decrease, because I would say that might be associated with lack of coverage, and we reduced a lot of services that were available when being paid through Medicaid, and so that might not necessarily be great that we're reducing it, because once care is needed, it might be more expensive.
Great point. The value comments go both ways. Areas where we've seen maybe a reduction may not necessarily be areas that we want to see a reduction. Meg?
I was just curious about hospice, because you don't see that as a separate breakout, and is that included under home health, or is that under other perhaps? And is that something that should be measured, since that's kind of a goal in terms of keeping people out of the hospital?
Yes, we have some data on hospice from the Medicare program, which we've reported on in the past, and we will do more with. I'm not sure if it's broken out, but we can do a pretty good job on that from just the Medicare data, because most of that spending is handled by Medicare information. So I can also get more information on this.
Danny Anderson, thank you. Welcome.
Okay.
David raised a very good point, which is the most complicated part. Most of you represent providers of different kinds of healthcare. And I'm sure you believe that the services you provide value. And as someone who uses a lot of your services, I too provide value. So on the one hand, in normal circumstances, the more one would spend on an area that has value, the more proud you would be that we are spending more, and including the idea of having coverage. Yet, we have the other side of the coin, where the general impression is that the American healthcare system spends too much money, and that if we don't get spending down, we're running out of our ability to pay for it. So one of the things that's so complicated, and I would say no one has a good answer, but it's worth having some discussion about, is how you tease out reductions in spending that are legitimate reductions in spending from reductions in spending that lead to less services and lower care. So many of us are very concerned with what's going on in Washington, where some people take great pride in the fact that they're cutting spending for Medicaid, and several of us are saying, oh my God. So some discussion of that going forward to try to figure out that sweet spot in that is probably as important an issue as we could deal with. And honestly, we talk about waste, and clearly, services that are being provided that add very little value. And if we can cut those spending, that's a win-win. But of course, that turns out to be often in the eye of the beholder. So it's worth having discussion.
Yeah, I would just plead for a scientific view of understanding variations. Steve Jenks, when he was at CMS, prior to my time, published very important papers looking at state-by-state expenditures compared to CMS data on state quality, and there was no relationship. So just as in international studies, we have some evidence that states that spend more don't necessarily get higher quality for it. I'm not saying that's a conclusion here for sure, but I do think we should remain very curious. Marcy?
I think you almost have to go program by program to look at some of it. So for example, the reduction in nursing care facilities. One hypothesis on my part would be that the 5 pioneers working together all put in programs around preferred SNF, and then started to have physicians who were working under contract or for them in the SNFs and managed down lengths of stay considerably, which would drop down SNF. So you could probably look to see how much of that dollars was related to those 5 pioneers, which would be a good indicator, I think, on something like that. Another one would be total joint replacements. So we and many others have significantly dropped the number of people who go to rehab rather than home post total hip or total knee. And so that would be another category where you could look to see what additional are we spending on home health care versus what we're spending on SNF, and then increasingly people are starting to measure the outcomes based on patient-reported outcome data, so you could start to look and see, what in fact has changed that has led to a positive patient experience, and we didn't have a good sign. So I think we're going to have to hypothesize programs and then try to get a sense of, what might the impact be.
But we tend to focus on utilization. And going back to you, John, when you do some gross comparisons between the United States and other countries, it's not at all clear that we overuse healthcare relative. We go to the hospital less often. Our lengths of stays are lower. We go to the doctor less often. We use less drugs. The problem often is on the prices. And so when you look at these spending patterns, it's less, we tend to, every time we have this discussion, we focus on utilization. But the reality is that much of our higher spending is a result of higher prices, the old money statement. And so it's not surprising that James found that, because often the reason why spending is higher in state aid or in the United States versus Europe is because of the fact that our prices are higher. It's not utilization. So we need to break this down even further, not so much by use, by area, but also by how much of it is utilization versus how much of it is prices. And of course, I think it's hard to do, but David, that can be an assignment.
Okay. And of course, there are, these are, correct me if I'm wrong, David, but these are raw spending numbers, and we do know that there are some differences in our demographics in Massachusetts compared to the United States. We're a slightly older population, but a healthier population than most other states. And so how we think about some of those adjustments, and of course, a very high income state and cost of living state, which may contribute to a portion of this as well.
Okay, so let me just go on to just two more. The next slide does drill a bit further on the home health spending. You notice before. We brought in Medicare data to be able to break out the home health into Medicare and everything else. Unfortunately, we couldn't decompose everything else at this point. But you'll see that what's driving our higher home health care spending is really not Medicare. Medicare spending in blue was 2013 and the orange is 2014, and we're about maybe 15-20% above the US average in spending per person. But outside of Medicare, you can see that we're about 3.5 times as high. That's where the most of the delta is coming from. So probably a mix of commercial and mass health, and we don't know entirely. And we are aware that mass health, home health spending was high in this year, and that's been talked about. The program is aware of that, taking actions to drill down and learn more about why that is. Striking differences. And on the last slide, what we did was break down what is the contribution to our higher spending compared to the US average, in terms of what accounts for the higher spending in terms of dollars, and just what are the major categories. So, you see below that, in 2009, our higher hospital spending accounted for 42% of the reason that we were a high spending state. By 2014, it accounts for just 34% of our excess spending, so that dropped. And $854 of our excess spending is now in the hospital category. You can see that long-term care and home health combined, that has grown in contribution to our excess spending. Now it accounts for even more than the hospital share. Professional services has stayed about the same, and you can see, as I noted, Paul, drugs now account for 5% of our higher spending dollars in 2014. Okay, so that's the overview of this data. We can't drill too much farther down within this data, but we of course are going to continue to bring all the other sources we have to bear on understanding by provider, by region, by payer, everything we can do in the cost trends report and in the future.
Great, thank you, David. Any other comments or feedback just on that particular data? We had some good comments along the way. Seeing none, I will move on to the next topic, which, as I mentioned before, hopeful to get some of your feedback on, is our 2017 cost trend hearings. So the dates of the cost trend hearings, Colleen?
They're October 2nd and 3rd, Monday and Tuesday at Suffolk Law, same as last year.
A couple of keywords here that try to encapsulate some of the different goals and purposes of the cost trend hearings. Of course, this is a unique state activity to enhance the public transparency of our healthcare spending trends. We have typically engaged a wide variety of different stakeholders, both between market participants, but also state government and leaders and national experts. We have asked questions trying to evaluate our progress and different market participants' efforts to meet the comprehensive goals of cost containment and delivery system transformation that are part of Chapter 224. We do have a process for creating a written record every year through both our written testimony process and through the oral testimony process. And as well as basically being able to enable a really broad public engagement in the work of the HPC and in the work of all your organizations in terms of reducing healthcare spending. So some potential modifications that we're considering this year are to streamline the hearings a little bit and bring it down from, instead of 2 full days of hearings, to more of a day and a half, and to and conclude our hearings around lunchtime on the second day. Would note that we've had 2 full packed days for the 4 years that we've conducted these hearings. Many of you have sat diligently and dutifully in your VIP seats for the entire 2-day hearings. It is a long 2 days, and so considering a little bit more focus in terms of those hearings. And with that would be a little bit more of a focus on the witness panels, where in some years we've had up to 6 witnesses per panel. I think considering bringing that down to no more than 4, so that we can really have an opportunity to have some good dialogue with each of the witnesses, and not so much of having everyone answer one question and then suddenly our hour and a half for the witness panel is been taken up. And to have where we've had in some years up to 4 national speakers come, really thinking about 1 to 2 for this particular year. As below, you can see some of the potential themes that we've been considering and talking about internally and with our commissioners. Many of these are, I think, are reflective of both conversations that we've had at the Advisory Council, but also around when we held the benchmark modification hearing this spring that identified some areas for potential opportunity in reducing spending growth, to check in on some of those areas: avoidable ED visits, readmissions, referral to post-acute care, the shifting of care to community or routine care to community hospitals and other high-value settings as opposed to higher-price settings. Interestingly, this year we do believe that we have now sufficient run out on some of the data to be able to do a retrospective analysis of some market transactions that have occurred in Massachusetts in terms of what was the actual impact in terms of patient patterns and spending after some mergers and consolidations that occurred a few years ago. And so I think that will be enlightening to have a conversation armed with objective data with some of those organizations that pursued consolidations in the past, what has actually occurred in terms of their goals and results from those consolidations. And then I think reflecting a continued interest from this advisory council that so much of the delivery system transformation relies on payment transformation and the move away from fee-for-service. How are we progressing on some of those topics? So this is a non-exhaustive list, but if we're going to hold ourselves to a day and a half, we're also going to need to do a little bit of focusing. Interested in both your feedback on the potential modifications, what you thought worked well in previous years, and where you would recommend that we make sure that we spend some time talking about. Laura?
So first of all, the data that you presented earlier, I want to congratulate the Health Policy Commission. I think you really drove a lot of the change that was reflected in those numbers. And we spent the day yesterday talking about pharmaceutical transparency, and there was some thought or notion that really transparency doesn't have much of an effect. And I think all you have to do is look to the work that was done here to see it has tremendous effect. So with that, 3.1%, how we get there, I don't see pharmaceutical spending on this list, but I imagine it could be embedded in there. I think that would be a major theme that my plans would want to cover. I also think there's some interesting work that ICER has done with a pharmaceutical manufacturer who actually came to them to say, we're about to put this high-cost drug out on the market. We'd like to work with you to think about a range of appropriate pricing. And they actually did that, and they actually think that's a great model for the nation and a great model for us. So I'd love to hear more about that during the hearing process. I think as we see transactions, there's going to be a big one coming to the HPC of consolidations. I think we do want to sort of see where we've been, if people are holding true to their promises, and how that's impacting patient care. So I think those are some of the areas that we want to focus on in this next cost term.
And
So I think one of the things I'd be interested in having some dialogue about is, as you all know, the Medicaid ACOs will be launching, I think, January 1st of next year. It would be very interesting to hear where people are, what the plans are, what the focus is for success with those Medicaid ACO models. Maybe hearing from another state or another example where they have been successful with that. I think the other thing I'm particularly interested in hearing is any data that you have as far as are we seeing any success at sort of reversing the tide of so much care going into the teaching hospital, keeping more care in the local community.
thank you. Comments reflecting the Medicaid ACO launch in January and an interest in seeing how that process is going, and perhaps some other states, Oregon or Minnesota, who have also attempted some Medicaid ACOs, their perspectives. And then secondly, around, just repeating, for the shift in community or routine care from the community hospitals to downtown Boston, where we've been tracking that, certainly an area that we will keep a focus on that. I think we've been updating those numbers regularly, and hopefully have some new insights this year where we've been able to also look at physicians, practice groups, and where their patients are seeking care in terms of community hospitals versus academic medical centers, and maybe some variation that exists among physician groups as well.
You just mentioned the physicians groups. As part of the market transactions, would you also be looking at the consolidation of physicians groups and the cost?
So I think we're probably still a year away from being able to do that, but that is absolutely part of our plan, where we have also seen in the past not just hospital consolidations, but also the physician consolidations and what those impacts have been. It's a little trickier on the physician side, and the research and cost trends team can speak to this, but we rely on the claims data for that, and attributing the claims data to the physician groups is not an easy endeavor, but is absolutely something we are keenly focused on as well, because those have been some of our major transactions in the past 5 years. Ron?
So one thing that I was concerned with, especially after the AMA meeting with the Washington Climate, is that organization started to address what the ideal healthcare plan should include. And I think when you start to talk about high value care, we need to really make a blueprint for what services really matter in a healthcare plan, because what we're going to get is low cost plans that don't cover anything if they do anything at all. And so I think we really need to be out front in what's been of value in the state, what lowered our mortality, what improved our healthcare. That's something that I think that this organization would be very helpful in leading the country in doing.
I think it raises maybe a question, and Paul, I'll get to you and your feedback, but I know we have not necessarily had a large focus in these hearings on changes at the national and federal level, and the idea of there's so much uncertainty right now, even today and this week, in terms of trying to think about how that may impact or shape or frame the context for these hearings that could be occurring in the fall. So I think it's an open question for us as we think about, this being a state effort. If there is significant changes on the federal level, how do we consider that as part of these hearings and as part of our work? Paul?
I just would be a process suggestion. Perhaps run an experiment with one of your panels, rather than do the questioning, where Stu really makes an effort to make sure that each commissioner gets asked a question. You try one of them congressional style. You give members, 4 or 5 minutes, because sometimes there's some interesting issues that I've historically observed get raised, and there isn't the ability to follow up because of the way that Stu tries to navigate amongst the commissioners. So we've got to try one that way, especially when it's a heavy hitting ones where probing is sometimes can be useful. Let's just see what happens. It's interesting.
Dan?
So you mentioned, we're gonna be seeing another kind of wave of massive consolidation in the Commonwealth. And so I think do we have any predictions of where this is leading? Will every organization, every hospital be part of a system or not? Is that something that the commission has any views on?
Yeah. So I think it's fair to say that we will have a significant proportion of the meeting devoted to consolidation and what we know and what we don't know and what we can do and what we can't do. So, I think it's fair to say we all understand that we are consolidating and continue to consolidate. Some people argue that this is a good thing, others argue that it's not a good thing. So, I know that we are going to focus that effort. Now, we would welcome ideas on how to make that discussion meaningful. We generally, in the last couple of years, have brought national experts who have done significant amount of research on the impact of consolidation, and I expect we will continue to do that. But if any of you have ideas on how to make that discussion more fruitful, we will. Nothing more I can say right now. We will be doing our job, which is to analyze these consolidations and their potential impact, and also to look back on what's been happening over the last couple of years with respect to areas that have already consolidated and promises were made on the impact. And the question is, have the promises been fulfilled in terms of more efficient care? Have the promises been made about not raising prices?
Yeah, I'd like to ask you guys a question. So many of you sat through hearings. I have sat through one. If you think back, what's one of the most important or helpful things that have happened at a hearing from your point of view? Maybe you recall a segment that was really good that we should.
I thought last year the social determinants of health were really good, and we talk about it a lot, but we never talk about how do you really integrate that into a health system. Really are going to improve people's health and reduce their reliance on health services and promote health.
Now, I'll reflect on that point. I thought Warren Taylor's presentation was excellent last year, and I don't mean to keep bringing up her quote, but Kate Walsh's kind of a perspective on where does the health system's responsibilities begin and end on some of these social issues. I thought was a really challenging question for all of us to consider.
And I think that hopefully and unfortunately the Prevention and Wellness Trust Fund didn't get continued funding, and that was a pilot year that was a way to bring community and healthcare and the environment, the social conditions and the community together. And it's unfortunate, and I think we should figure out a way to continue that work.
Marcy, Meg?
I was going to say exactly the same thing, and also echo I thought Kate Walsh's comments were right on. And one of the things we might think about is we have district funding that the Mass Health ACOs, talking about our 5-year plan, that the Mass Health ACOs are going to be getting specifically to try to cross some of that line and say, how do we reach out beyond just the medical office to spend some of it elsewhere. And I'm sure we're all in different places, as well as struggling even to fund the things within our own offices that deal with some of those factors. So that might be an interesting conversation to pick up from it and see where people are actually trying to place their bets around that.
Let me just caution. I'm a big believer in social determinants and believe that it's one of the main reasons why our health indicators are not as good as what's going on in some other countries. However, if many people think that the only thing we're going to do is just add more money, for social determinants on top of all the money we're already spending on healthcare. I think the reality is that's just not going to happen. So going back to this issue about trade-offs and the need for the healthcare community to redirect money within the money that's already being spent on healthcare to social determinants is really where the discussion needs to be. You know, when you talk about ACOs, that's a good example of that, where you see major delivery systems saying, you know, I can get better bang for the buck by redirecting money that previously was being spent on healthcare services to others like coordinated care and going out into the community and helping housing and so on and so forth. So I think we need to be strategically thinking about it, because one of the things that I hear from time to time is, well, we need to spend more money on social determinants. And I'll say, that's fine. I'm a big believer in that. But where are you going to get the money? It's just not going to be added on top of the big spending for healthcare.
I'll come back to you, Cheryl. Meg?
I think as we've been working in our application for a certified community partnership, part of what we're looking at is the framing of working to the top of your license as opposed to spending more. So how do you look at the work and say you can work with lower skilled workers to do things that can raise the red flag, but then brings in the higher cost factors. They need to go to the physician, they need other services. So that was one piece, and that I think that's part of the exciting piece for the district funding, is that we're already starting having those conversations. I think the other is that it's been a lot of anecdotes as opposed to metrics. And one of the things that we've been working on in the last 12 to 18 months is to really try and put in more outcome measures as opposed to process measures. So that's great, we do it on time, but does it have an impact? And so we've been working with Mass Health and others to say, let's put in some measures that we can really show is that making a difference in terms of cost and quality.
Thank you. Laura, I think I saw you next, so.
I think to Dr. Berg's question, I think one of the more interesting panels that I remember probably the year before last was when we had some of the CEOs in to talk about mergers that had been undertaken, what they were doing to make their system more efficient. And I know you said you're going to focus on this. You know, for one, I think that more work needed to be done, so I hope folks are in a better place. But you know, again, we're going to be faced with a very large transaction going forward. Some of my board thinks that's going to be very positive for the market. Some are concerned. I think the national data tells us that when providers come together, prices go up. So I think where I sort of sit is just holding the system accountable. So I think more expansion of that would probably be the most beneficial thing from my members' point of view that you could do.
Yeah, I'll reflect on that for a moment too. I think in that particular panel, what we heard a lot of testimony was it's too early. We're still working on it. These things take time. I think we've now had a little bit more time and the benefit of some objective data that we can bring to bear on those conversations. Is there a big transaction happening that I don't, people keep talking about?
I'm not saying anything.
I see that smile on your face. I notice people look.
Cheryl, I think you wanted to just reflect about the Laurel.
I did have a question as well. So, I just wanted to bring up an issue that people don't often like to talk about, but I think it's important, and that's the issue around end-of-life care. And there's some interesting, I mean, obviously we know that it's raising costs, but aside from that, you know, there's a lot of ethical issues around there. There's you know, we've seen all the news around the baby in the UK, and there's some interesting programs that are going on, respecting choices, and I don't know if you're familiar with that, but in Wisconsin, it's been highlighted, and they've gotten a lot of really good results out of that. I know I've had conversations with Massachusetts, and I actually put together a workshop with a theologian, an ethicist, and a hospice care nurse for the public, and it was a really interesting conversation. And I just feel like it might be something that either brings someone in from Respecting Choices or one of the hospitals that have done this, but it's an issue that's going to get increasingly prevalent as people get older and we have more technology. And obviously I'm a technology advocate, but I'm not an advocate of inappropriate use of technology. And I think that that's where we have to really sort of have those conversations and it's a huge cost implication. So,
Good point.
Yeah, we have a couple of our investment grant programs that have been supporting advancements in terms of serious illness care, and many of those programs are working on enhancing access to palliative care and hospice care, and again about reflecting the preferences and wants of individuals and their families facing these decisions, and certainly an area that both intersects with the great quality of care that one expects facing these situations, but also there are cost implications as well that are significant. Steve?
So, back to potential modifications for a second. You know, it strikes me that participation in the hearings is not optional, okay, for providers. There's needed to come and testify. So it's become something that I observe that folks want to survive as opposed to embrace. And I wonder whether there's a cost trend 2.0 that is about, because you look back 3 years, we talked about consolidation. That's still happening within the market. We've talked about reimbursement and variation of reimbursement rates. That hasn't been fixed. Last year we focused on pharma. That's still an unanswered question. They're talking about mass health. We still face the same uncertainty today. So we're pointing out a lot of problems, but we're really not breaking down silos in between when the cost of hearing is over and everyone goes back to the regular day-to-day. And if you're going to streamline the hearing, maybe we could do a midterm report, that's a 1.5 day, halfway through the year, to follow up on the trends that were discussed at the cost trend hearings and see whether or not there's some work that you or the commission might undertake to move certain things forward. And so that we embrace the idea of social determinants. It doesn't have to be more expensive, but how can we break down silos between providers to make sure that some of that stuff is happening organically, simply because it was pointed out the cost trends that we think is the right way to provide for our patients. I'll just follow up on something that Cheryl said just for a moment, which is it may be a panel on prevention, wellness, trust, and chart, because they were not intended to be long-term programs, as you all know. They were intended to be bridge funding until the next generation of healthcare took over, and that was going to be through accountable care organizations, and the idea that the organization would make those contributions to community hospitals or prevention wellness because it made sense to keep their patients healthier, thereby making them less expensive. So we haven't quite got there yet. So maybe, you do some extraordinary work with CHART around the state and pointing out the good work. Maybe that's a panel at the cost trends to point out some of the best practices from CHART and some of the best practices for prevention, wellness, trust, so that the legislature can take another look at whether it's worthy of additional funding. So those would be my thoughts.
I love the midterm report. I love that idea. Colleen, you might have another idea. Laura?
To Steve's point, just to caveat one thing, I think with the Prevention and Wellness Trust, probably one of the reasons it wasn't funded is it's very duplicative, I think, of what some of the efforts are going to be going forward with the ACOs, what's going on with the health plans, what's been going on with the health plans. So I think that if Prevention and Wellness Trust is going to be funded in the future, we want to be sure that it's funding things that aren't being done. So, for instance, they had, I think, a proposal around, they were focused on elderly number falls. That's something SCOs have been very invested in working on. So I just think that was an issue, but there was some duplication, and I think some would say that DPH actually is the place for a lot of that to happen. So just as we think about that, we were going to take that on. I just want to be sure that things they're focused on are not happening somewhere else in the workplace.
I think that's a debatable point whether this was duplicative, and I think whether we hypothesize that maybe some of this will be backfilled in the future. I tend to agree more with Steve that the vision was that we were building, making these investments into the healthcare system that was going to be transformed around payment reform, and we have not made the progress that we expected in terms of payment reform to date. And is there a conversation that needs to happen in terms of how we continue to make the right investments, absolutely not duplicative, but that contribute to that system that really is delivering on the goals. So.
I wanted to, I really liked your ideas, A, about end-of-life care, but also you brought something else up that I just want to throw out to the group, and that's technology, IT in general. You know, I can't go to a meeting now where, particularly for people who are under the age of, pick a number, 12, but who are big on the new technology and the new toys that are coming out, and how they're gonna disrupt and fundamentally change our healthcare system. And, you know, I keep thinking about add-ons as opposed to substitutes. And on the other hand, technology going forward has the real potential to change the way care is delivered and the potential benefits. So I'm wondering whether a technology-related discussion is something worth having, whether you guys have any opinions on that.
Marcy and then Ron?
I think it'd be great to talk about technology and somehow, this isn't a fully fleshed out thought, I apologize, but the intersection between payment and technology are really important. So for example, I've had this discussion with Laura, who's obviously very helpful, so I'm the one who's got the action item here, but trying to put telehealth in place within our organization with our patients. For when a patient comes to us and wants telehealth, I have zero ability to tell them before they have the encounter whether or not they're going to pay a copay, whether they're going to pay for a full visit, or whether in fact I'm not even allowed to charge them based on my contract. And you know, this is just sort of the tip of the iceberg. I think you know, there are other barriers. I have people in my office almost every day talking about texting and why we're not texting more of our folks. And in fact, there are laws about texting that require people to opt in for very specific things, and it is no small effort to make all that happen. And I've got lawyers who worry about class action suits if we opt everybody in rather than opting out. I mean, there are a number of these issues that are barriers to implementing technology that would streamline the system that I think could be a really enlightening conversation and maybe drive some action at a state level, legislatively, or maybe we need to look at some federal legislation. And I'm hoping Don's going to tell me there's a way around the texting.
My way around this is just do it and not apologize later. Well, let's talk. I think that Marcia's point raises the question I have, which is what my passion, as everyone knows, about delivery system reform. Payment is interesting, but it's not as interesting as changing care. And I'm hearing some avidity when you talk about end-of-life care, about Marcia's question about perhaps having some of our time devoted to imagining the new delivery system. What are some of the innovations that are out there? Who's leading? What are some of the really innovative things around the country? Get to the care side, not just the payment side.
Right. Yeah.
I think Ron had excellent. We'll come back over.
So in terms of some of the technology, I'm a cardiologist in treat heart failure, and a group that I know about has developed a thing I call the Magic Cup. One of our things is how much fluid you take in a day. And this device actually, if you use the same cup in an Apple Watch, will measure how much fluid you consume in a day. So you can imagine how useful that would be in managing heart failure. And the cost of the watch is about the cost of the DNA visit. So this is the kind of, there are a number of these things that I'm aware of that are happening that would change the home health market in communication between providers and patients that would perhaps dramatically lower costs and improve the quality of care. In terms of the consolidation, there are two ends of the spectrum. One is when an area is completely consolidated and you have a big system and very higher costs. But on the South Shore, we're seeing an example of incomplete consolidation. So we have 4 or 5 different systems competing. And what happened is that with the consolidation, the resources were aligned in an unequal fashion. So all the surgeons are in one group, all the neurologists may be in another. And what happens in that case is that when they don't have the service, the patient gets sent to Boston. So it's exact opposite of what we want to have. So nationally, we looked at a mechanism for getting patients to have a process for having out-of-network care approved. Because in fact, the neighborhood neurologist may be high quality and much cheaper than having to ship that patient to Boston. So that was really a national discussion because If you're gonna do narrow networks, you have to have network adequacy. If you don't have an adequate network, then it raises costs, and so there's pretty good data on that. So the South Shore is sort of the prime example of the 5 or 6 PCOs competing where our costs are going up rather than down.
Yeah, it's just, so the theme here is identify innovations that will make a difference, and then help us understand what the financial, legal, regulatory barriers are those innovations. That's an analysis we can do to accelerate progress toward the delivery.
But Don, let's go to Marcy's comment, why payment reform is really critical for delivery reform. As long as you have fee for service, having simple things like texting and phone calls being paid for in a fee for service world, there's strong evidence that's going to lead to increased spending. So if we could change the payment system for capitation, and you guys then, as a delivery system, decide what works better, it would be so much easier.
Even for risk patients, we still can, for the same
No,
reason.
I understand.
It's built on a fee for
There are two
service
separate
policy.
issues here. One is the legal and stuff like that. The other is the financial that makes the payers nervous about a add-on service that's easy to do with a payment rate that becomes. So it's where, you know, the main point here is that payment reform links very much into delivery. So it's not a question of either.
So I was told last year that Kaiser Permanente crossed the line now, more than 50% of their encounters are
That's exactly
are virtual, and that's not an accident, that's because they've got consolidated.
Vic, I promised you, next. Well,
Thanks, Steve. So I think from a behavioral health perspective, technology is absolutely something we should be taking a look at. And I think to Marcy's point about what's allowed and not allowed, I think focusing on that could be helpful, because I think there's a lot of myth out there of what's not allowed. And I think as our members start to look at technology, the more they educate themselves, the laws, especially in the behavioral health realm, which are oftentimes more stringent, there is flexibility. And we can use technology creatively to change the delivery system, as Dawn referenced. So I think if we had a panel to talk about that and help flesh out what is actually allowable and not allowable, that could go a long way.
Thanks, Laura.
You know, this is my baby, so.
Yeah, of course.
But, I just would caution you that we don't take it from the aspect of kind of a hammer looking for a nail. So talking about, there's lots of innovation out there. I mean, I run the health economic group at Phil, and so I'm always asking people, what's the clinical problem you're trying to solve? And where are the gaps in the care for that problem? Because during the last meeting here, I heard a lot of providers talking about the fact that these patients are leaving the hospital and they fall into a black hole and they don't see them again until they show up again. There are ways that telehealth and remote monitoring and other things can help solve that problem. But the other point is that you have to connect it with payment somehow, because you gotta pay for this stuff somehow. And we have been, I think, thinking about telehealth in a fee-for-service perspective. So it's a thing that you pay for per encounter, and that's not how telehealth for the most part works. So within the context of delivery system reform and a capitation or a bundled payment, how do you capture the cost of those? Not in the same way, because if you're looking at retrospective claims data, you're never going to capture the cost of that. So I mean, I just think we have to be creative about how we pay for this, as well as, you know, as well as starting with what's the big problems we're trying to solve in Massachusetts and what innovations are out there that can help us really do that.
Great point, Cheryl.
I would love to hear some stories from some folks, patients that have been in systems that have merged, and see if they're changing any of their experience at all. Is it just a change in experience for the providers or the system, or are the people actually feeling any of this? And second to that is in our chart program, I feel like we have changed the experience because we do text with our folks. A lot of they're primarily behavioral health challenges, and they run out of minutes. And unless you text, you can't communicate. So they fall into a black hole because you can't find them. We do text with them and introduce ourselves. It's very sort of high level, light stuff, nothing too need for personal or medical. But it's a way to engage, and then you build trust, and then you meet, and then you actually connect them to the places that already do the social determinants of health work. We're not having to pay for it. We're hooking them up with programs that already exist. So I think that the thing I would most love to hear is maybe some examples of where the people themselves have felt the change, and that would be hard work and maybe some of these consolidations.
Thank you, that's a great point. And I know many of the CHART program teams, have a strong community health worker presence and have found, the texting and engagement through that, sometimes through secure texting portals, but otherwise just where many patients are struggling with social isolation. It's a way to stay engaged, connect, how you doing today, you need anything, how you feeling, and it's been a very effective tool as far as I understand it.
We also have the secure texting with the providers. So if I'm with someone and there's a question, it's really quick to securely text with the providers. So that's been a great technology for us as well.
Marcy and then Paul.
I'd like to second Steve's comment about everybody being under oath. Clearly if you're asking about past actions in the context of market transactions or whatever, you might need people to be under oath. But if we're having a discussion about the future of innovation and technology, you're really asking them there as experts, and that might be a better approach for that testimony.
Yeah, it's a good point, and I think one of the constant places where there's been some consideration over the years is this a place where we are a congressional hearing, where we are putting people under oath and asking them very pointed questions and seeking their testimony, or is this a place where we're bringing leaders together to have a conversation around challenges and opportunities? And one would structure a hearing and the questions in different ways depending on that. And I personally believe, I hope we can find a way where it can be a little bit of both, because I do think that there is a unique value in having a place where we can ask some difficult questions and have a clear public record on some important questions, but also at the same time allow for a space to have conversations, speculation, and about the future. So that's a great point, Marcy and Steve. Paul?
Steve's comment for me, where he was saying, like we're talking about price variation, don't make progress. We're talking about moving from fee-for-service to capitation, and we made limited progress. Or talking about consolidation for the most part, just what happens. I have a panel on what are the policy political barriers, that are stopping us from doing the things that we all said we got to do. I'm somewhat tongue-in-cheek, but I'm also very serious about it. I think we ought to name it in a more direct way. So otherwise, you go through the motions we all seem to go through and talk about the same issues. But I've been crossing a line by already to do that this morning.
But that's why you have presentations by different people. So I think it behooves those of you who are concerned about it not happening to articulate why it's not happening. You're not going to have the people who want to change it articulate why they're either wanting to do it or trying to prevent it from happening. So.
Well, if you said to me you're going to devote a panel for people to sort of observe where, from a consumer perspective, for example, where the barriers seem to be, whether it's politics or policy or other things, I would be happy to organize such a panel to talk about that.
No comment on that one. Any other thoughts or reflections on the cost trends hearings? Ben?
Yeah, just like to reiterate what Laura said about including pharmaceutical companies in this. We all know it's a major cost driver, but they do have this special exemption in the Enabling Act. So I know last year's cost trends report noted how opaque the pricing of pharmaceuticals is. There's bills pending right now in the legislature that would add pharmaceutical representatives to the list of stakeholders that to testify. So I guess this is a question for you, David. How much can the hearing focus on drug pricing without, this enabling act without changing the enabling act?
So we did include a recommendation in our last year's cost trends hearings that the enabling act should be amended and changed to include pharmaceutical manufacturers among the list of identified witnesses that we can call to testify. To date, we have relied on the goodwill and the kind of community partnership from some of those entities to come and provide their perspectives. We had Bob Kaufman from Mass Bio 2 years ago, and her name escapes me, but we had someone from the Pharma Association last year. But we lack that ability to call individual manufacturers and ask specific questions around pricing and trends. I think one reflection I have for you and just for the group, certainly we conduct these hearings in the context of our performance against the benchmark. And we don't know yet our performance against the benchmark in the most recent performance year. That will be released in September by the Center for Health Information and Analysis. And that always provides a good window. Where are those cost drivers in that year? And if we exceeded the benchmark, what were some of the reasons why? We always want to bring those to the benchmark, to the hearing as well in terms of having some further examination. But I appreciate the comment. Laura, did you want to add anything on that?
No, I would just say that if the pharmaceutical manufacturers don't want to come, some states are doing interesting things. The example I gave you, if that company would be willing to come in and talk about their experience, I think that really is a best practice that I would love to see adopted by more manufacturers.
Great. Well, more to come on this. Thank you. And if you have other thoughts or ideas offline, please do let us know. In terms of pre-file testimony, we are going to be continuing our tradition of asking organizations to provide some written commentary to us in advance of the hearings. We are reflecting that there are a lot of demands on provider organizations in particular this year, both with the Mass Health reform, with our ACO certification program, with our next round of the registration of provider organizations. And so I think you'll be encouraged to know that we have taken another look through our pre-file testimony and we'll be streamlining that as well, specifically for provider organizations. We know that this does require some of your time and effort, and so want to be reflective of the fact that we know that there are many demands. So look for that soon, and hopefully that will be something that does not require tremendous amounts of your organization's time, but also adds real value to the hearings and to the public record as well. So look for that soon. In terms of the rest of the presentation, I think we can dispense with going through more of the slides. I do want to just kind of orient you to one thing, which is a continuation of the conversation that we had at the last advisory council around the strategic priorities for the Health Policy Commission. We had what I thought was a really great conversation in terms of you reflecting to me and to us around what are some of the areas you would like us to see that HPC continue to focus on. So we've been continuing to evolve kind of our structure and our framework for thinking about the work of the HPC and how the different policy levers contribute to the overall goal of reducing healthcare spending. And so the latest version of this is included in your presentations. I'll bring you to, I think, slide 20, which is our consultant arrow, which combines our activities and strategies, policy priority outcomes to the vision and an ultimate goal. In addition, you'll see in a few slides after this some proposed focus areas for our work moving forward, really focused on two strategies, which you'll see on slide 25, which is around promoting right care, right place, right time, and secondly, improving healthcare affordability through market monitoring and accountability. And really thinking about the activities of the HPC and the strategies of the HPC falling within these two focus areas moving forward. This is still very much in development, and so again, I'll leave this for you to look at. and to provide commentary to me offline. We're going to be continuing to talk about with this, the board with this moving forward. But again, just trying to provide a greater framework around the work of the HPC and how it contributes to our ultimate shared goals. So the other pieces of information in here are an update on our ACO certification program and a quick update on our healthcare innovation investment program, again, for your perusal and review on your own time. So with that, if there's any remaining comments or questions that people have for today's meeting, seeing none, we're going to end a little bit early, and thank you for a great meeting. I think the next time we'll see you is November. So we'll be in touch before the cost trends hearings and hope to see you all there. Have a great summer, everyone. Thank you so much.
I'm sorry.